Welcome to rePROs Fight Back, a podcast on all things repro. I'm your host, Jenny Wetter, and each episode I will be taking you to the front lines of the escalating fight over our sexual and reproductive health and rights at home and abroad. Each episode, I will be speaking with leaders who are fighting to protect our reproductive health and rights, to ensure that no one's reproductive health depends on where they live. It's time for rePROs to fight back. Welcome to rePROs Fight Back. Today we're going to tackle another listener request, which is always fun. And this one actually came together perfectly because I had just read an amazing article covering it. So today we're going to talk about self-managed medication abortion. I'm super excited to have Megan Donovan with the Guttmacher Institute and the author of the article I just read here with me today to talk about this important topic. Hi, Megan. Thank you for being here.
Hi, thank you so much for being here. I'm really excited.
So why are we talking about self-managed abortion?
Any conversation about abortion and reproductive health, freedom, or autonomy should include discussion of all of the available options for how a person can access abortion. And that includes self-managed care. You know, self-managed abortion is not new, but there's a lot of fear and misunderstanding out there, really stemming from an earlier era in which the options were generally sought in secret and often unsafe. Especially now, as we contemplate a changing Supreme Court and the unfortunate reality that we may see abortion rights seriously undermined in the coming years, people are understandably eager to talk about and picture what that might look like. But they sometimes fall back on ideas and images that do stem from that earlier era and really haunt our understanding of what it might look like. And so they fall back on concepts like the coat hanger or the back alley abortion. But the world around us is changing. People access healthcare in all kinds of new ways. They use technology and their phones and consult doctors and order birth control from apps on their phones. And so as we continue to update our notion about what healthcare is and how people access reproductive healthcare, including abortion in the 21st century, I think it's really exciting and even comforting to know that how we access abortion has come a long way since Roe v. Wade was decided in 1973.
Yeah, I think you're right. I think often if you hear about not having abortion in clinics, you really just do hear, you see the ubiquitous coat hanger everywhere. And that's kind of the end of the conversation. There isn't kind of the fuller, what would it look like? Safe and legal abortion in the United States is really associated in our minds with a sort of medicalized setting and clinic-based or provider-based care. That's what people think of and where, many people feel comfortable. And so challenging that or talking about abortion not in that setting can be uncomfortable for people. What is self-managed abortion? Yeah, so there are a variety of ways in which people, may seek to self-manage their own abortion. Medication abortion in particular holds great promise for the future of abortion care in the U.S., and that's what I'd, really like to focus on today. That's what the article was about, as you mentioned at the beginning of this conversation. Just to, make sure that, listeners are with us as we think about what this looks like. Medication abortion was first approved in the U.S. by the FDA in 2000, and consists of two medications, mifepristone followed by misoprostol. And so when we're talking about self-managing a medication abortion, we're talking about the process of administering that medication and completing an abortion without the direct supervision of a provider. It's important, though, to understand that
we're really thinking about this as a model in which people should always have access to complete and accurate information in order to self-manage their abortion safely and effectively, and should also always have access to a provider should they, want or need one at any stage of the process.
There are a number of barriers to making that a reality in the U.S., and that's definitely something your article addresses. So there's I think you broke it into two types of barriers. So maybe let's focus on the first one, which is accessing medication abortion in the U.S. in general.
That's right. I think that is a helpful way of thinking about this. There are a number of barriers to realizing a fully supported, self-managed model of care. And you can start by thinking about some of the primary barriers to medication abortion generally. So one of the biggest barriers that inhibits access currently to medication abortion are the reMS. Now, that is a very wonky acronym that stands for Risk Evaluation and Mitigation Strategy. The reMS are a set of restrictions imposed by the FDA on mifepristone, the first drug I mentioned that's part of the True Drug Protocol. reMS are a tool that the FDA has available to it that are really supposed to be used for drugs with high-risk profiles to ensure that the benefits of using that drug outweigh the risks to the consumer. But given its extensive safety profile, mifepristone and medication abortion don't belong alongside drugs typically subject to reMS. So we have what are really a set of ideological restrictions stemming from anti-abortion sentiment that limit the distribution of mifepristone. And what that really means at the end of the day for someone seeking medication abortion is that they can only access it by finding a registered provider in a few specific settings, such as an abortion clinic or medical office or hospital. They cannot access the medication through pharmacies, for example, like you can with most prescription drugs. So someone needs to find a provider who is able both to prescribe the medication to them, but then actually also has it stocked and ready to be given over on site to the person. It is completely different to your typical experience where you might get a prescription from a provider and then be able to access the medication you need at a retail pharmacy, or these days, online through any number of online pharmacies or options. And so getting rid of the reMS to begin with could really expand access to medication abortion in general in the U.S. by opening up and expanding the pool of providers that are willing and able to offer medication abortion, and making the options that people have for how and when they, purchase and access the medication a lot more convenient.
So beyond the reMS, there's also other state restrictions that impact how people can access medication abortion.
Sure. And so just to make sure it's clear, the reMS are a federal level set of restrictions imposed by the FDA. And so, that's at the national level that we're dealing with them. And then when you get down to the state level, there are a number of other types of restrictions that states have imposed on medication abortion over the years. Two really primary ones are that 34 states limit the provision of medication abortion to physicians, despite recommendations from bodies such as the World Health Organization and the National Abortion Federation that a number of other clinicians, mid-level clinicians, advanced practitioners can safely and effectively administer medication abortion. And 19 states require the clinician who is providing medication abortion to be physically present, which essentially bans telemedicine for medication abortion. So these are a couple of the other types of restrictions that we can work to remove that would just start to open up the ways in which people are able to access medication abortion as one way of, getting us closer to a world in which self-managed care is more fully accessible and supported.
Maybe we just want to touch a little bit on because saying that physicians need to be the ones to prescribe medication abortion sounds, I think to a lot of people, sounds like common sense. So maybe you want to flesh out a little bit by what you mean by mid-level people can do it so that people are understanding what we're talking about.
So there are recommendations from bodies such as the World Health Organization and the National Abortion Federation that when it comes to prescribing the medication and explaining to people, providing the information people need to use medication abortion, that that can be done competently, safely, effectively by nurse midwives or other classes of nurses, for example. These are clinicians who actually do a lot of medical care that perhaps in a past era we associated primarily with physicians, but in this day and age are, have sort of increased authority to, do a lot of the clinical care. And it's been shown that they can facilitate and support someone through medication abortion, as a physician might be able to. And so when we think about how states could, just at a basic level, expand access to medication abortion, it is to. So when we talk about one of the ways that states can expand access to medication abortion, it's to, make sure that all of the clinicians who are, able to deliver this care have the authority to do so, and it's not being sort of unnecessarily or perhaps politically limited to physicians.
Good. I think that makes sense and makes it a little bit clearer for people, like who we're talking about when we talk about more people can provide than what is currently allowed. So the next type of barrier you identified are barriers to a fully self-managed model. Do you want to touch on what some of those are?
We were just talking a lot about the ways that we could increase access to medication abortion as it's currently approved in the United States. Or even further, I should say, in the absence of the REMS restrictions that are, sort of unnecessarily limiting it at the moment. But as we look ahead and really think about a model of care in which self-managed abortion using medication is sort of fully supported and accessible and available to people, there are also a number of barriers to kind of achieving that environment where people can access the information they need and access the medication and have the support that they need or want at any stage. One of the biggest, I think, is this we've already touched upon, and that's stigma and fear. And we've talked about it already, but it's worth, I think, mentioning again that people need more information, and they need to understand that, medication abortion is very safe and effective, and over 15 years of, use in the United States has shown that to be the case, and that the evidence really is there to suggest that that people, may be able to self-manage it without the direct supervision of a provider. And so working to kind of educate people, help people become more familiar with medication abortion firstly, but then also get more comfortable with the concept of self-managed medication abortion, and with the fact that we are talking about a model in which people have the information and the support they need to do this safely and effectively, I think is really, really important.
I think that's important because I think part of it is also just kind of demystifying abortion, because I think when so many people think of abortion, they're not thinking medication abortion and don't really understand that that's an option for a lot of people.
I think that's absolutely right. I think we have a lot more work to do here in the U.S. to talk more openly and honestly about abortion and abortion care, and that you're right, that people in general don't realize that medication abortion is an option, or is an option that is widely used in the United States. Since it was approved by the FDA in 2000, medication abortion really has kind of transformed the nature of abortion care in the U.S. And, as recently as 2014, which is the most recent data, we have medication abortion accounted for 31% of all non-hospital abortions in the U.S. And I think that's just something people don't understand or are not fully aware of.
So one of the other barriers you talked about after stigma and fear was over-the-counter status.
Sure. So we talked a few minutes ago about the REMS, which I keep kind of referring back to, this set of FDA restrictions that really kind of set mifepristone and therefore medication abortion apart from other similarly safe drugs in the way that people access it. But even were you to lift the REMS and sort of therefore expand access to medication abortion generally in the U.S., that would still limit what we're talking about to prescription-based care. So moving the medications over the counter would help ensure that people can access both medications directly instead of requiring a provider to write a prescription first. And I want to keep going back to this idea and this point because I think it's worth repeating that sort of the vision here is that someone would be able to, access in a way that's comfortable to them. Whether that's online or whether that is by sort of interfacing with and talking with a provider or someone first, but would be able to access, the information that they needed in order to feel supported and in order to know how to self-manage an abortion with medication safely and effectively, but that ultimately they would be able to access that medication without first needing a prescription, and therefore could conveniently and easily go into a retail pharmacy or order it online in order to self-manage their care.
I think one of the things I think of when I think of moving it into a pharmacy is the dangers of running into religious refusals.
That's a really good point. And it is a barrier that, could potentially stand in the way. We know from not even over-the-counter status, but even, prescription-based drugs can sometimes be difficult to access if someone seeks them out at a pharmacy, for example, where a pharmacist refuses the care based on ideological arguments or beliefs. I think continuing to work on ensuring that an individual level refusal is never a barrier to care is one thing that, is a necessary step towards just sort of promoting access to sexual and reproductive health care in the U.S. in general. So ensuring that even if an individual doctor or pharmacist has an objection to providing care, there's always a seamless backup in that, that office or pharmacy has to ensure that a consumer gets the care, is a principle that kind of applies to any type of care that we're talking about. But I think that, self-managed abortion also could, by making the medication available in more ways and, increasingly through online applications, for example, could also be one way that people could, find routes to accessing care that are currently limited. And even beyond refusals, that could mean expanding reach to, rural or otherwise underserved communities.
Another barrier would be affordability.
Yeah, affordability is a critical topic of conversation anytime we're talking about access to sexual and reproductive health care and, including abortion. And, in this world in which we're talking about medication abortion being available over the counter, it's kind of a perverse fact that over-the-counter status can sometimes have the effect of making a medication less affordable if someone's insurance company won't cover over-the-counter medication without a prescription. So this is one of those things that we as advocates need to be very mindful of as we are promoting policies that move towards over-the-counter status and promote over-the-counter access, is that we need to be working at the same time on ensuring that over-the-counter status meaningfully expands options and doesn't restrict them. So by working on the sort of insurance piece of it and other kind of affordability mechanisms to make sure that we don't have kind of the perverse effect of taking it out of reach of people.
It's not more accessible if people can't afford it.
Exactly. That is the critical point. And so we need to be ensuring that the people can access it in more places, but in a way that is meaningful. And a key piece of that is being able to afford it.
And then I think the last barrier you touched on was criminalization.
No one should be punished for seeking to terminate a pregnancy. And unfortunately, there are a variety of state laws that have been used to punish people who have been suspected of seeking to self-manage abortion. And so these are another set of kind of barriers that we need to be breaking down, both in terms of seeking to change these policies where they exist, seeking to seeking to educate people, including law enforcement, about abortion and about self-managed abortion, in order to ensure that someone who seeks to end a pregnancy is not punished for it. I think it's worth noting that both the American Medical Association and ACOG, the American College of Obstetricians and Gynecologists, oppose criminalization of self-managed abortion.
What would access, if we were able to achieve affordable access to self-managed abortion, what would that mean for women?
Facilitating access to self-managed medication abortion is really about ensuring that people have access to the full range of safe and effective methods of abortion care. We are talking about, one method among many, but the benefits of self-management can include, enhanced privacy and enhanced autonomy. I think something that may be really helpful for people is to think about and not underestimate the benefits of being able to end a pregnancy in the setting of one's choosing and surrounded by the community or not, that one chooses. So, involving the people that one chooses to involve in that, or enhancing, the privacy that someone wants for that care that they receive.
Yeah, and I also think about we're seeing clinics being forced to close for restriction reasons, and being able, if we were to live in a world where all of a sudden we could have access to self-managed abortion care, women in rural areas, that could be a real game changer for them to be able to access it via telemedicine and then be able to go to a pharmacy or get it online would make things a lot easier for them.
That's right. I think there's a couple of important points kind of embedded in what you said, and it takes me in a few different directions. But, your main point, I think, is a critical one, is that this is a, way of hopefully expanding the options available to people, including the way people in rural or otherwise underserved communities could access care, and absolutely has a lot of potential for, a telemedicine model is not necessarily a self-managed model, but it's something close to it. It's something that could more robustly develop if we, for example, got rid of the REMS, where people could use technology to, access a provider remotely and get that information and care that they want. I think it's very important to acknowledge that self-managed abortion can provide another option for people as we face ongoing, restrictions against abortion and sort of we look ahead to a world in which the Supreme Court may take action to even further limit access to abortion. But I do want to sort of be careful to caution folks not to think about self-managed abortion only as a workaround to reduced access, or to therefore start thinking about it as like a worst case scenario or last sort of chance that someone has. I think there's a danger when we talk about it as a response to restrictions to kind of present it as a something for the desperate. And I think self-managed abortion can be something so much more positive than that. Something that allows someone the autonomy and the freedom and the privacy to manage their own experience, whether that is in part because of restrictions or for other reasons. And I also think we really need to, as we work towards fully supporting self-managed care, we need to make sure that the piece of that is making sure that people actually still have access to a provider if they decide at some point during the process that they want or they need one, or they self-assess that they may need one. And so we don't want to lose sight of the importance of complete and accurate information and, access to a provider if someone wants or needs it.
And it's definitely important because self-managed abortion is only, especially if it's medication abortion, is only effective up to a certain point, in which case you would definitely need to go to a clinic, and you need the clinics to be available for women to be able to access safe care.
So medication abortion is currently approved in the U.S. for up to 70 days after a woman's last menstrual period. And so if we're thinking about it in that framework, part of the process of self-managing an abortion involves, being able to self-assess if you're eligible, and then, being able to access other care if you're not.
We always kind of end the podcast focusing on what can people do to take action? So what can people do to, what steps can they take to make self-managed care more accessible in the U.S.?
The first and foremost, most important thing is to do exactly what you and I have just been doing for this past little while, which is talk about it and keep talking about it and ask questions and share information and help break down that barrier of stigma and fear that we've identified a couple of times during this conversation. And that'll happen by promoting access to information and resources and being open and honest about abortion care, and, what we want from the experience. There are, of course, other ways that people can help, facilitate access to self-managed abortion. Those, include supporting organizations that are working to break down the barriers. The list could go on and on there, but just to name, maybe one player that is really doing a lot right now to help people overcome barriers to self-managed abortion and help ensure that people are not criminalized for seeking to end a pregnancy is the SIA legal team, SIA. But, if people are really interested in helping out, there are a number of organizations that are working on this. And I think similarly, advocates can, get involved in the work to get rid of some of the restrictions we've talked about. And, first and foremost, I think on that list is working to lift the unnecessary and ideologically motivated federal restrictions known as REMS. One last thing to just hit upon before we close the conversation. I just talked about supporting organizations that are working to promote access to self-managed abortion and to ensure people aren't punished for ending a pregnancy. And one of the organizations that jumped immediately to mind was the SIA legal team. And I think I would be remiss if I didn't acknowledge in this conversation that even as we look ahead to this model I've been talking about of kind of a fully supported, model of self-managed care that is, part of how we in our laws and our policies support people's access to abortion in the U.S., it should be noted that there is evidence that that some people are already self-managing their abortion care in the United States, including using medication. There is evidence that people may increasingly have access to both mifepristone and misoprostol, but also that people have used misoprostol alone to self-manage an abortion. And I think as we think about that and how we support people with access to reproductive health care, we always need to remember that no one should be criminalized, as I've said, for seeking to end a pregnancy. And we should be, moving towards fully supporting them with all of the information and resources that they need. So in that fight, the SIA Legal Team is one of the organizations that really comes to mind, supporting women where they're at and looking ahead to a even more supportive model of care.
Great. Well, Megan, thank you so much for being here. I think this was a really informative conversation.
Thank you so much for having me. I had a lot of fun.
For more information, including show notes from this episode and previous episodes, please visit our website at reprosfightback.com. You can also find us on Facebook and Twitter at reprosfightback. If you like our show, please help others find it by sharing it with your friends and subscribing, rating, and reviewing us on iTunes. Thanks for listening.